Good evening, everyone, and namaskar, and a very, very warm welcome to yet another episode of Safe. Just give me a second. I will do a few introductory slides and then I will hand it over to Dr. Shubhangi. Just give me a second. So, as you all have been here, so you're aware that this is an initiative by ANEI Patient Safety Fellows. SAFE stands for Safety Awareness for Excellence. So, this is a monthly learning sessions, and we do that every month, 7 to 8 p.m. And we are catching up on this day because we missed one. So, in June, we have two. So, our ANI Patient Safety Fellowship is being done in collaboration with Patient Safety Movement Foundation USA. And our fourth cohort is right now on, and third cohort will get their certificate this year during the ANI Annual Patient Safety Conference at Guwahati on September 19th. And we hope we will be releasing the request for applications for this year soon, May in the month of July. So we also will be able to induct the new people. So all these things are just a second. I think Davinder, you are not able to admit people.
Yes,
There,
ma'am.
there are many people there. Please go to the participants and you can see the people on the right side. There'll be waiting room. So you just have to click admit. Okay.
Uh,
All right. So,
it's in white only.
it's okay. So we have an annual calendar under SAFE, and we have been doing all the sessions. They are a mixture of quality improvement projects done by cohort 3, and then there are new topics. So today we have got Dr. Shubhangi, who is going to talk about healthcare associated venous thromboembolism. Maybe a topic not very frequently discussed in nursing quarters, but definitely a problem that we face in our hospitals. So before I hand over to Dr. Shubhangi, I also would like to say in July, we will have Karishma discussing her QIP on identifying and reducing hypoglycemia events in the hospital. So look forward to seeing all of you there in July. And as I told, please save your dates and calendar. Annual Patient Safety Conference will be at Guwahati this time on 19th September. It's a one-day conference. And please do watch out for exciting pre-conference activities. There will be, competitions and, paper, QIP, etc. will be released. So please watch out for that. With that, I'll say thank you and I stop sharing and I invite Dr. Shubhangi to please take the stage, take the podium, and take the session on VT, healthcare associated venous thromboembolism. Shubhangi,
Yes, good evening, ma'am.
good evening, good evening. Please come on the video and
Ma'am,
then,
video it is disabled, ma'am.
okay, one second. So let me, one second. When you just stepped out, I kind of put it off because only chair was there. Okay. Okay. You are visible now. You can share the presentation and so we will take the questions in the end. So as you listen to Dr. Shubhangi, if you have questions, you can keep posting them in the chat box and we'll take them at the end of the session. Yeah. Thank you. Over to you, Shubhangi.
Thank you, ma'am.
Yeah. Please put it on the slideshow, please.
Yes, ma'am. Good evening, all. And at the onset, I would like to say thank you very much, Thank you, madam, for all your guidance and support, constant support always. And I'm really proud to be an ANI member. Thank you, ANEI. Thank you so much. So today it's the topic that we are talking about healthcare associated venous thromboembolism. It's very important topic because people take, like when they are hospitalized, a lot of things are being neglected by the patient itself, and nurses plays a very vital role to educate. Every day we can just pray, like we can take a pledge that every day one patient or two patient we can educate about something or something whatever comes in mind, whichever patients are coming to us significant to that we can educate. So this is very important topic. I would like to share, starting only, I would like to share one example in my family only, where they are staying at Igatpuri, and they are all were like able to take a railway hospital facilities because her husband was in railway. She was quite a healthy woman and maintaining ideal body weight and not even a, very sedentary lifestyle. She was very good, like a homemaker and working very nicely. And like last 2 to 3 years she was suffering from this venous thromboembolism. She was admitted in hospital, and very surprisingly the plot was so long, very much long it was. She need to admit almost for 3 to 4 hours, and she was got operated for this, and she was suffering a lot. She was like very much pain and all that, and at home she has to just stay immobilized because of the severe pain and all. And then she went to a super specialty railway hospital. She was taking a treatment, and one of my friends was working there. So they were so keen, the healthcare team members over there being in railway hospital, because she was taking treatment, and little bit initially she was irregular. Then she did not turn to the hospital, and they all were worried because she was having very big clot, very long extending, like you can say almost 15 16 more than 16 centimeter, that much big clot she was having in her veins. So she called me, my friend, she called me from hospital, and she told me like, Shubhangi, what happened, your auntie, she is not coming to hospital. So just talk to her, and because they were not having mobile her number. So that time, or either in Igatpuri there was network issue, so they were not able to trace the patients. So she called me, then I called to her, and then she was followed. So that much healthcare professionals, they were very keen and very caring for that patient. And now also, when I spoke recently with her, she was telling me that they call me, they ask me, how are you, how was your health? So I was really happy, like, so every healthcare workers has to be there. So VT, actually, this why this is important, because it is a very preventable, this condition is very much preventable. It is in our hand that we can prevent it. So like now VT is the fifth most frequent reason for the unplanned hospital readmission after surgery. As much as 70% of cases of healthcare associated VT is preventable. So that is all in our hand. So if you see a data from US, up to 9 lakh people in US are affected by the venous thromboembolism each year. And from that, because of the hospitalization, cancer treatment, and pregnancy, among that 9 lakh, almost 60,000 to 1 lakh people, Americans, they die because of VT every year. And sudden death is the first symptom in about 1/4. That is 25% of the people who have pulmonary embolism. Why VT is important? Because it is being associated with a pulmonary embolism, which is a fatal and very threatened conditions. So I have another example for this. I'll share it later on. This is one of the study that is being done in Hyderabad, Telangana, where they have, it's a very nice study. We can, like everyone can do this kind of a studies with the multi-center studies. So they have assessed a prevalence of risk factor for the VT among the pregnant women, because pregnancy, because where I was working, I, of course, pregnancy has to be pampered, but previously, pregnant women, they used to work very hard, working in farms and at home also. But I have seen some of the like Yuns Institute now. They take it very, very much precious and caring pregnancy. People don't want to go for outside posting because I'm pregnant. Then they will use small tables to elevate their feet, and uh, becoming more and more sedentary, especially the pregnancy that I have observed. So we took it very, so this study that concluded 20% of the pregnant women had intermediate risk factors. There are different kinds of levels of risk factors for the VTA, which will eventually we can learn in to assess the risk factor. Then there are 40% had significant risk factors for the development of VTA during pregnancy and postpartum period. See, when we come across any pregnant woman, now what we focus everything most of the times for ANC, all our visit, all our investigations, and baby care, breast care. So no, this is a very, very important. We never talk about this with the pregnant woman, what can happen. So this is very significant result that 40% had a significant risk factors for developing a VT during the pregnancy and postpartum. So VT, you can see the normal veins and the normal blood flow is there. What happens when there is a deep vein thrombosis, you can see in this picture, and what happens that from that thrombus, a small amount of it, that embolus keep on moving. It moves with the flow of the blood. So wherever it goes, it can go and clog that vein. So it can cause a significant problem. When it reaches to the respiratory system and it blocks their pulmonary system, what will happen? Again, it leads to pulmonary embolism, so which is a very, very fatal conditions. So VT is a medical condition that involves the formation of blood clots in the veins, which can lead to serious complications like DVT, deep vein thrombosis, and pulmonary embolism. That is what VT is it is very, very important and very, very significant to know about, to learn about, to educate our patients all about. This you can see this with picture, the venous, there's a thrombus and there is an embolism which is moving across the blood flow. Along with it moves to the flow. So body has a tremendous amount of defense mechanism. Body tries to do lot of things without even our knowledge. Body tries to repair at a very, 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 very higher level, a superficial level, very, very higher level. Body tries to repair the things on its own. So human body, learning and human body, it's very, very difficult. What happens when there is a normal vessel, the resting the platelets are at resting. And what happens when there is an injury, any kind of an injury? What happens? The body, the platelets, they try to line up at the wall of the vessel so that they will try to seal to prevent the bleeding. But that is not enough. That sealing may not be enough. So what happens? There is a chemicals that is being released. You can see that the chemicals, various chemicals are released. That is the activation of clotting mechanism. And what happens there when these chemicals are released? There is this yellow color you can see, that is called as a fibrin. That fibrin is formed and there is a thrombus formation, and which causes which is able to create a seal to prevent a blood loss. So because of the injury, it happens, which is a natural response from the body. But who are the people? Why they are prone for developing the venous thromboembolism? So very important, this virtuous triad that is being developed in 1856. So you can remember SHE, she. S stands for stasis, H stands for hypercoagulability, and E stands for endothelial injury. When because of the stasis, which are the condition which causes the blood to become very, very slow motion of a blood? So stasis, what happens? Immobility, paresis, then age above 40 years, then there are varicose veins, which makes the people to restrict the movements. Obesity, people, they don't try to very sedentary lifestyle. Then heart or respiratory failure, stroke patients, they are prone to bed for many days. Polycythemia, then spinal cord injury, anesthesia. Then you can see that the people who are traveling for a longer duration, especially in the flights, they have to stay. So in that case, they have to just walk and just get up and walk in between the flights. So this is one of the reasons, stasis, which is the risk factor. Then next is endothelial injury. Any kind of injury to the vessel, to the veins, which can lead to venous thrombosis. Just now we have discussed what happens when there is a injury what is the normal response of the body. So when there is an injury, there is a surgery, especially the pelvic surgeries, then trauma, smoking. If there is any history of previous VT, then patient has got invasive catheters like IV line or a central venous catheter. Again, it can cause endothelial injuries to the vessel, and that mechanism is getting activated. Then, which are the condition where there is hypercoagulability? What happens? Hypercoagulability. Blood tend to become more, try to be, it is become more coagulable. So clotting is possibilities increase. And when it is, when there is advanced age, when there is a malignancy, when patients are on cancer therapy, estrogen therapy, especially hormonal replacement therapy, then pregnancy, there is a lot of the circulation that is being increased, then postpartum, then inherited or acquired thrombophilia is there, then nephrotic syndrome, then there is inflammatory bowel disease, then there are antithrombin deficiency and protein S and protein that C deficiency. These are the conditions. So it is very easy to remember the risk factors. What makes the people prone to develop the VT? That is the virtuous triad. That is stasis. You can remember a mnemonic SHE. That is stasis, hypercoagulability, and endothelial injury. Then these are the various risk factors which I have discussed, like patient's age above 60 years, then history of VT. Then there are chronic conditions like heart failure, respiratory diseases, inflammatory disorders. Then also there are some genetics, abnormalities which can also make people prone for developing the VTE. That is factor 5 Leiden prothrombin gene mutation or antithrombin deficiency, which increase the susceptibility of clot formations. Then pregnancy, because of pregnancy during there are a lot of hormonal changes, increased blood volume, and there is a reduced venous return. The veins, their job is what? Just to carry the blood then to the inferior vena cava, and it goes to the right part of the heart. Then hospitalized patient, those are not moving for a longer time, then staying in the hospital or having surgeries. Then I remember, some of the hospital in one of the government hospital which I have seen, like because I was working in ICU, I was a student, so I went there. I just wanted to move the patient, to mobilize the patient in ICU. We were given a posting, but I was being told that so this is not our job. We don't take any decision for patients mobilization, because I remember where I was working, there was a lot of autonomy. We used to do a lot of things. We were given a lot of autonomy regarding the patient care. We used to mobilize the patient. Then so I was being told over that no, this is no, we don't take any decision for this patient. Let doctor decide and let them decide, and the physiotherapist, they will do their role. We don't have to do. Then smoking, then taking a birth control pills, and then cancer. All these are the risk factors for the venous thromboembolism. Now, how we can identify the sign and symptoms? Very important. That stop the clot. Remember this mnemonic for the VTE, that is blood clots. Why what are the sign and symptoms for VTE? When there is a swelling in the legs, then there is a tenderness, severe leg cramps are there. Then there is a out of breath, you can see the part of areas, because why? Because of that. Then lightheadedness, then there is a chest pain, then there is a leg discoloration, then there is overdrive, and pulmonary thromboembolism, pain and swelling, then tenderness or cramping, and there will be a leg fatigue. The person will be more fatigue. So these are the sign and symptoms we can this is one more important sign for to identify whether the patient has got positive for venous thromboembolism. This is part of the Homan sign, where the patient is patient's lies supine with the knee extended, and we do a manually we do a dorsiflex the ankle while applying the pressure to the calf. When there is a pain at the calf, which indicates the deep vein thrombosis. Definitely, along with this sign, lot of other things has to be simultaneously done. Other clinical evaluation, diagnostic evaluation, that has to be simultaneously. It has to be confirmed. Then there are other more risk factor like surgery. Major surgery, especially orthopedic surgeries. hip or knee replacement, neurological procedures, and abdominal surgery, because these are the surgery which takes a longer duration. Shorter the duration of surgery, there is definitely a low risk of developing venous thromboembolism. But certain surgeries which takes a lot of time, then I remember when I was working in ICU, one of the patient who was a old patient, and what happens, the patient was underwent a orthopedic surgery, major surgery, and she was kept in ICU. So we were taking lot of efforts. In between, that patient develops some respiratory complications. That patient develops respiratory complication. Because of that, we have to do a lot of work for that patient. The complete team, the whole team, we were working very hard for that patient, mobilizing that patient on chair along with ventilator, then giving her supine position because of the respiratory complications to develop after the surgeries. So we were doing a lot of efforts for this patient, and almost we think that she will get cure. And in between, I was off duty for 1 or 2 days. When I joined, I came to know that we have lost that patient, and the comments that were passed, like in ICU amongst our colleagues only, we were passing that kya mobilize kiya, what we have mobilized. So what happens, why there is a sudden death of that patient? So these are the query things, like so this kind of example I have seen, because so many days she was hospitalized, and we have lost this patient. Then immobility, trauma, central venous catheter, prolonged hospitalization, infection, and patient susceptible, they are more prone for clotting. These are the factors related to the cancer. Because of the cancer, there are patient related factors, treatment related factors, and cancer related factors. Patient related can be, I told you, age, female gender, then race, African American, then prior history of thrombosis, comorbidities, when they have additional comorbidities, obesity. Then treatment related can be hospitalization, blood transfusion, patient receiving chemotherapy, surgery for cancer. Then cancer related factors can be advanced age, patients got severe metastasis, then site and type, like pancreatic lymphoma. All these things, they are more prone, when the patients are diagnosed with cancer, more prone for venous thromboembolism. These are the different types of levels of risk. While low risk, when I told you, surgery less than 30 minutes on patients under 40 years without any significant risk, which makes the patient at low risk of developing VT. Moderate risk, that patients with age between 40 to 60 years and surgery less than 30 minutes. So the patient has no additional risk factors. So major surgery, but major surgery in patients under 40 years with no additional risk concern. Then high, why the patient has got high risk of developing VT. Then surgery performed on a patients older than 60 years with additional risk factors, and more than, it takes less than 30 minutes. Patients over 40 years, again, he has got a significant risk factors and who need a major surgery, which keeps the person at a high risk of developing VT. Highest, again, patients, major surgery in patients over 60 years old, history of VT, malignancy, and or a hypercoagulable state. So these are the various risk levels which makes the, so we can assess this risk and we can take. There are studies which also have added some additional novel risk factors. Those are the risk factors like endometriosis, and there are repeated pregnancy loss. Those are like threatened abortions, threatened preterm birth and cesarean section. These are the pregnancy related novel risk factors for developing the VTE. This is the background, like what happens, blood clot, these are the symptoms. And we have seen the risk factors that were just triad: hypercoagulability, blood loss, blood stasis, and vessel injury. Now, how we can diagnose? We have to collect the proper history from the patient, proper physical examination. There are different types of scores that is being used by various hospitals. Very commonly, that is well score that is being used for, that is, then we can do a ultrasound. Then again, D dimer is also a test, a very important test. Then also pulmonary, this even they can do a CT angio also, that also can be done. These are the diagnostic tests. That D-dimer test, very important. Then venous ultrasound can be done, venogram, then impedance plate seismography, and lung ventilation perfusion scan also can be done in case of a pulmonary embolism that is being suspected. So how much the lung is being ventilated, which the areas of the lungs that we can do with the VQ scan. This is the lung ventilation perfusion scan. We can see this areas down in the picture B is there's a very poor perfusion that we can see. Now, what are the goals of the treatment for the venous thromboism, venous thromboembolism? So we have seen up till now what are the various risk factors, especially the virtuous triad. You can remember the mnemonic SHEC. So keep new clots. The doctors treat the blood clots to for what purpose? Like to keep the new clots from forming. For example, the heparin. It doesn't actually it doesn't do anything with the clot, but it doesn't allow the new clot to form. Then it stop the existing clot from enlarging in the size, then stop pieces of the clot from moving and limiting blood flow in other parts of the body. What will happen? The pieces of the clot, they becomes embolus and they go and reach to the pulmonary system. They can cause a pulmonary embolism in any area, which can they even can they can reach into the coronary circulation. So this is very risky area, especially when the patients are on atrial fibrillation. They are again they can develop a embolism and they can have a clot and patient can have a suffer a cardiac arrest. Then avoid complications caused by blood clots. These are the goals of the treatment. Keep clots from traveling to the lungs, brain or heart where they can be a fatal. So what are the preventive strategies for venous thromboembolism? There is a pharmacological prophylaxis, that is low molecular weight heparin, then unfractionated heparin, then newer anticoagulants, that is direct oral anticoagulants for certain patients can be given, depend on the patient's risk and sign and symptoms and history. Then there's a mechanical prophylaxis, mechanical, that is external compression devices, that is intermittent pneumatic compressions and graduated compression stockings. Then mobilization as much as possible, for frequent mobilization for patients who are able to, we have to mobilize the patient. Then physical activity to reduce the risk. This what I was talking, how we can assess the patients. This is a Caprini score. For this Caprini score, that is it tell you the point, the how much the patients are keeping for the low risk or a moderate risk, high risk, highest risk. So we have to take the patient's history, the age, the surgery and everything. So we have to give the scoring accordingly and calculate the score. So depend on that, we have to assess the risk of the patient for developing. This is Padua score for the VTA. This is again also will suggest you how much is the more than 4 points suggesting a high risk for VTA. There are different, mostly there, those are similarities are there in the score. This is again one more score, which is a Wales score, very commonly used various hospitals. This is again, which again includes that a patient has got any active cancer, calf swelling, solar unilateral superficial veins, or is there any pitting edema, previous documented DVT, patient has got any paralysis, paresis. So all these things, any recent cast, immobilization of lower extremities. So that recently patient is being bedridden. So all these things. So we have to moderate to high risk of vascular ultrasound is indicated, where we have to confirm the diagnosis. Then D-dimer may be used in either cause to rule out. So this we are talking about the mechanical prophylaxis, that is a graduated compression stockings. These stocking apply pressure to the lower legs to improve the blood circulation and reduce the risk of DVT, particularly in patients undergoing a long periods of immobility. I have seen one of the family, those who are those are a senior citizen, and he has only son. He used to travel a lot to the US and all. The female that is being, I told her to, I used to visit them, like, no, so female I told to, because she's very much, she is at home only moving at the house and not going for walk, and she has having a pain, so she was using this. So I told her to use this regularly. this talking. So at least because she was having very much pain in the legs because of the immobility. Then pharmacological prophylaxis, low molecular weight heparin, that is very important. Then direct oral anticoagulants. So as a nurse, we need to very, very important role when patients are receiving anticoagulant, because we have to watch for any sign and symptoms of bleeding. So we have to regularly monitor the anticoagulation therapy, PT-INR for warfarin. Then these are the anti-exif factors. These we have to check it. This is the intermittent pneumatic compression. The lower limbs are wrapped properly. So as a nurse, we have to take care of this when these patients are there. There may be a lot of sweating and patient may feel very irritating, and we have to make sure the patients are using this. It is being applied, it is working. It may be applied, but the machines may not be working. So we have to take care of all these things being a nursing part. Then there are different kinds of venous foot pumps are there. Foot pumps or devices that mimic the natural muscle action of the leg can help promote venous return in patients who are immobile. Then early mobilization, very important. Early mobilization whenever after the surgery to we have to make the patients to mobilize, then to restrict the range of motion, exercises, then minimize the bed rest, because patients, they are under our care and they were so much worried, what will happen to my surgery site. So they are very much anxious. Once they are entered, their anxiety level is definitely very high. So it is the nurses who can communicate, counseling them, talking to them, can get their really anxiety reliefs, and what is necessary if it is being told prior to surgery, especially. So what is our expectations and what is their role post surgery? How they can. One of my relative, na, she was very much reluctant. She don't want to undergo knee replacement surgeries because she was very much scared. Clearly, I told her what she was. She asked me my opinion. I clearly told her, see, this is a major surgery, knee replacement surgery. You have the major role. After the surgery, you have to cooperate maximally 100% with the healthcare workers, with the physiotherapist, so that your recovery will be as much as fast. So that is what very important, explaining these patients prior to surgery. So now, in between, just I wanted to tell you about this diagnosis. I wanted to in between. I remember one of my very close relative. I used to stay with her because she was having venous perforation, and she was taking a treatment in one of the BMC hospitals. She was taking a lot of treatments for that, regularly going. So there was her pain, there was a lot of bleeding at the lower limbs and all, no. So once she was actually she was traveling to her native place, because what happened, she was sitting for a longer duration, she started a lot of bleeding. So she called her daughter, and she came, you just come back immediately, don't travel to the native. And then what happens, she traveled back, and she was being admitted to the hospital. She was being, after 2 days, I went to see her. I was talking her nicely, and in between, suddenly she told me, like, yesterday something wrong happened with me. I said, what happened? So yesterday I was having chest pain, I was having sweaty, I was so sweaty, and diaphoresis and lot of things. I was, my mind was like something hard. I was, there may be some MI attack, something. So I said, what happens? Is that episode is being evaluated properly or no? That hospital was a charity hospital. So I was so much worried, and I called her daughter immediately. She was there only. So she said, no, 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 they have done ECG and everything. They have checked her nicely. But she was a case of the venous perforation. And after 2 days, I came to know that she is no more. She was very, very much close relative. That time it was stuck into my mind, like, no, why the diagnosis, why she was not being evaluated for pulmonary embolism. So that was very, very sad event, that I realized why that decision for evaluating her for that particular diagnosis, for evaluating the pulmonary, why it was not being taken by the healthcare team. So I was very much, we lost her because she was having venous perforation, bleeding. There may be chances, and the clot may have traveled, and she must have developed a pulmonary embolism. And they took. She was at home after. Uh, 2 days she came home, she was at home, and suddenly she started a severe. When she came back home after 2 days, after that episode, which was not being properly evaluated, and when she came back after 2 days, suddenly in the late evening, she got all these symptoms, and it was so fatal that we couldn't save her. They took her to the nearby hospital, but it was not useful. So very, very important. So what is the nurse's role in thromboembolism? So we have very important role. You have to obtain a history and physical examination of our patients. Then we have discussed now various risk factors. How we can assess the risk factors. We have seen in virtuous triad also, and we have seen different types of risk factor. So risk scales are there that we can use and identify the patient's risk for developing VT. Notify the doctor for two or more risk factors are there. If you came to know, then implement the DVT or VTA prophylaxis order as set by the doctors. Then educate the patient in preventing and detecting and treating the VT. We have to give a complete explanation what will happen to the patients. Then for a nursing intervention, very important mnemonic we have to remember, that is deep clot. So deep or what? Then what happens, we are very much culturally or socially, we are very much different than the other countries. We patient is having pain, we try to just give her massage. So what happens? So in D stands for don't massage the affected extremity. What will happen? It can cause dislodgement of the clot, and the thrombus can be traveled to the other parts of the body. So we have to, rather than we have to elevate. E stands for elevate the affected extremity above the heart level, which will reduce the swelling and improves the venous return. Then E stands for ensure bed rest. Patient has to, because patient may have a severe pain. Because of that, patient has to take a bed rest after developing this. Then P for pharmacological measures. That is patients on anticoagulant. I told you heparin. It is indirect thrombin inhibitors which enhances the activity of antithrombin 3. So we have to monitor the APTT. Now 1.5 to 2 times the normal range. Suppose APTT is more than 80 seconds. How you will interpret? How you will interpret that patients are at risk for bleeding. If it is less than 60, patients may not have a proper therapeutic level, and it may not be effective. So doctor can change the doses of anticoagulant. So that is, we have to inform and communicate. Then heparin can be used with warfarin, which is a vitamin K antagonist, which inhibits the clotting factor from using vitamin K. So we have to monitor the PT-INR. Again, same thing. If it is INR is international normalized ratio. If it is more than 3, patients are at risk for bleeding, and less than 2, again, patient has got risk for clot. So we have to watch. Then sometimes patients may be advised for the thrombolytics, that is TPA, which is a clot busting agent. So again, we have to watch for the bleeding. We have to observe the patients for any sign and symptoms of bleeding. Then C stands for compresses. Then we can give a warm and moist compresses to the affected extremity for the pain and improve the circulation. Then L stands for leg circumference measurement. That is a calf measurement. 3 centimeter or more as compared to the non-affected calf. So we have to inform how much it is. So because the normal calf circumference and how much is this affected calf circumference. If it is more than 3 centimeter than the normal leg, again it will we have to inform to the doctor and communicate. O for observe sign and symptoms of PE. I have shared you the example. So that is very important because it is very, very fatal and serious condition. It can take a life like within a second. So what are the signs and symptoms? Like sudden shortness of breath, patient may have coughing, then decrease oxygen saturation, heart rate will be increased, patient may have chest pain, anxiety. So all this we have to observe. Simultaneously, we have to teach the patient's relatives whenever on the discharge, during the discharge planning, so that they will take care. So, and T for the right tight compression stockings, that is thigh or a knee high. So fitted, it has to, nurses has to make sure that it has to be properly fitted stockings. It has to be applied correctly. Then, because it may prevent the post thrombotic syndrome, which is very patient gets a very severe pain after this event. So that is called as a post thrombotic syndrome, PTS. So then other treatment modalities can be a vena cava filter, then clot busting procedures like thrombolytic therapy, that also can be a part of treatment. Now, again, as a nurse's role I was talking about, we have to assess the risk of the patient, then administer timely prophylaxis, then patient education, very important. Patient education, explain the sign and symptoms of venous thromboembolism, the swelling, pain, shortness of breath. Then encourage medication adherence, especially patients are on anticoagulant therapy or a warfarin therapy. They have to monitor regularly the PT-INR level. Then yeah, they have to inform what action they can initiate when there is a changes in those normal levels. Then early and regular mobilization, support early ambulation post-op, then reposition immobile patients regularly, then compress devices that is there. And now these are the various complications of the DVT. Those are bleeding from the use of anticoagulants. Then I told you a serious complication, that is pulmonary emboli. Then post-thrombotic syndrome, that is PT. Guess. Now, what are the various quality improvement initiative nowadays? Quality very important. Then these are the initiative focus on standardizing the care, then improving the patient outcome and ensuring adherence to evidence-based guidelines. The goal is to reduce the incidence of hospital-associated venous thromboembolism. So we have to monitor the incidences. Then we have to implement the various protocols, that is systemic VT prevention protocols. So we can do a risk assessment, we can do a lot of audits, what are the readmissions post surgeries that we can then we can track various VT incidences, why, what is the reason. Then education and training for healthcare providers, so ensure awareness of VT risk and prevention strategies, and regular update on best practices and guidelines changes. Then benchmarking and external reporting, ourselves we can compare from for the time period, we can compare with the external bench, what are the benchmarking and what are the for example, if there are a national or international benchmarking, so where we are standing, so that can be assessed through various audits, and we can do a lot of projects, and we can us do the assessment, and QIPs we can conduct. So a lot of data we need to conduct, and incidents we have to track. So these are the various references that are being used. And thank you so much. If you have any doubt, I hope I'm on time. Thank you, ma'am.
Yes, you are very much on time. So you can stop sharing, and we had been having some
Yes,
very
ma'am.
good discussion here. So somebody's asking, when do you call it HAVT? What is HAVT?
Yes, ma'am.
There's some Swati, you only can answer what is HAVTE.
Hi,
HAV.
ma'am. Good evening, ma'am. I was asking about hospital-associated VTE. So, what is the criteria that you are making it as an HAVT?
See, HAVT will be, obviously it is something that is happening in the hospital itself. So even if the patient, see, anything that happens inside the hospital becomes healthcare associated thing. So I think what the question that Swati is probably asking is that, is there a definition for HAVT like your hospital acquired infections?
Yes, ma'am. Also, the duration I'm asking, like for how long the patient must be admitted, and we are considering that as an HAVT. Like sometimes patients are coming with the already with some symptoms, sign and symptoms. So, are we considering that, or there must be some time duration for that, right?
Can anybody help hospitals who have protocols? Can you opine? Hello, there are many people in the session. Can someone uh, give an answer to Swati if there is any definition of? That's a very good question.
Ma'am, good evening. Nisha here. Ma'am, I have worked in international setups as well. There's no particular definition that we have come across for the time frame. But if the patient has a pre-existing condition that involves coagulation diseases, then they are left out of the HAVTE. And patients who have acquired during the treatment in during the hospitalization, which involves surgery procedures or anything that happens during that comes under the HAVT category. That is how they classify the patients overseas.
Okay, I am just looking at the Google to understand is there any definition. So, as per that, there is a word called HAVT for sure, and it's a quality and safety indicator. That also it says. And in some countries like UK NHS, preventable HAVT leading to death is classified as a never event. I think in the US also there are 13 never events that it should never happen. So I'm just give me a second. I'm going to read that out. So most systems use a 90-day window post discharge to classify VT as hospital acquired if the patient was admitted for an acute condition or procedure. So I think by and large, as Nisha told, if they have any pre-existing conditions when they are admitted. So now it's very important. How do you identify a pre-existing condition? Only if you do a risk assessment. I also wanted to share that there is slight difference between Caprini, Padua, and Wells. Caprini is specifically for patients who are going for surgery. Padua is non-surgical patients, and Wells is actually a predictive tool that there is a probability of developing VTE. So they should not be confused. So I think most important is to do the risk factors. So somebody has shared a good study on PubMed, nowadays. Very good. Nice to see youngsters very quick on their fingers and going and getting details. So that's really nice. So how do you capture as indicator, numerator, and denominator? Now, obviously, there is no standard definition for patients of VT in our country. So if I have to do that, what will be my numerator denominator? Obviously, people who develop VTE, patients who develop VTE, and you will take the patients who were found at risk. So, VTE is something, the risk assessment has to be done for all patients, right? Then only you will know how many patients were at risk, and then finally, who developed any complication. So I would like to go back to more, I think, lot of knowledge, Shubhangi. Thank you so much. You covered a whole lot of things, but the nutshell is not too much of gyan. It is more about, understanding the patients who are at risk and educating and doing the right thing. So I'm going to tell you two stories rather. One that is quite old. I mean, long time ago, I was in Saudi. I had learned there is DVT and VT and P and all I know. So I was working in the ICU, young. I was just 22, 23 years old. I was part of the Code Blue team. So suddenly there is Code Blue coming from the surgical ward. So when I go there, I see this very obese Arabic lady on the floor, and people are trying to resuscitate. So there's hardly any space because nobody can move her because she's very fat. Okay. So obviously they were resuscitating. So I just called the assigned nurse and I asked her, what is this case? So she told me that this is post cholecystectomy. I said, post cholecystectomy. Aye. Then I said that when did you move her? So she said, this lady was not wanting to move at all. And today she got up to change her dress. She was dead. So this is a classical story. I will never ever forget this, because she had all the risk factors, but nobody bothered to move her. to convince her to say that it's very important she should come out of bed. Now, that is the most important lesson I would like to give to everyone here, because we all are smart nurses. We learn all the GAN. How do we translate them so that the patients are safe? That is the $1 million question that I would like to ask. That is one story. And after that, every time, I remember when I was a nursing student, how I was taught that when patients have cholecystectomy, olden time it is open cholecystectomy, right? How they will have hypostatic pneumonia because they will take short breaths because of the incision high up here. We learned all that. But how many of us actually take pain to ensure that this patient will take a deep breath? Give them the deep breathing exercises. That's one, you know, example. The other real story is not very, very old. I was in Fortis Vasant Kunj. This was before 2010, between 2006 and 10. So we get a call from the airport that, they need an ambulance. There was a German patient being shifted, and they told that he's getting admitted with pulmonary embolism. So when he came, what was the story? He had taken a direct flight from Germany, and he just slept. It's a long flight, and he had no idea that he is predisposed to DVT or whatever. So he was lucky he did not have a major embolism. He had a small one. He was coming to address a conference near Fortis Vasant Kunj. So he to us. He missed his lecture. He was kept in the hospital, and he was given all the heparin and everything. Scan, everything was done. And post that, the patient was, educated and discharged. So nobody is above the risk of DVT. And I also would like to share my personal story. First time when I went to US, someone told ki, ma'am, you should wear your stockings and go. It's a long flight. So I bought stockings and I wore, and I was more uncomfortable with that stockings. Anyway, somehow I managed. And the next time I decided not to wear the stockings. But what did I decide to do instead of that? I told myself that every 2 hours I will get up and I will walk in the aisle of the plane. So I was aware, so I could do that. But there is possibility that many people are not aware and they think, oh, it's better to just sleep off. And many times the position of their leg. I have seen, people just sitting cross-legged like this on that, and they're going to sleep. Maybe many of us are lucky, nothing happens. But if you have a risk factor, there is a possibility that you will end up in trouble. So ICU nurses, how obsessed I was, obsessed to sit my patients out of bed after their sponge bath during rounds. It will be a competition. I hope that that will be the feeling and the ambition for most of our nurses. You know, like Shubhangi mentioned, why should we be waiting for the doctor's order and for physiotherapists to come? But unfortunately, I have seen a lot of sad stories where our nurses are very quick in writing that patient refuse to mobilize. They think writing that one line will save them, but it will not save the patient. Where is our moral compass? Where we have told that we will educate, we will try to convince that they should be walking around. If we tell the patient very clearly that you are going to have this problem if you don't move around, they will definitely walk, right? So we should own our own patients. I totally agree, Nisha. I think it's lacking in our young nurses. But I would say if it is lacking, it's because they don't have role models. I still will take the responsibility as a senior person that we don't have enough role models to show. So there is an idea that came to my head. I'm going to share in this forum now. There are multiple risk factors for every patient. One patient will not have all risk factors, many of them will. And so far, we know what are all the healthcare associated conditions that can happen to a patient, right? So I'm thinking that maybe some hospitals have this. Maybe a separate risk assessment, area should be there in the handover, so that each nurse can know that what are this patient's risk and what are the nursing plan that is required. I can i can kind of see, maybe I never did that when I was in Fortis, but as I am talking about many risk factors like pulmonary and your VT, patients who are at risk of pressure injury, patients who are at risk of fall, patients who are at risk of developing hospital acquired infection. There are many of them, isn't it? So, just to get our nurses to think more smartly, maybe a risk assessment, the patients who have their own risk, what are the identified risk in a patient? If we include that in handover, I have a feeling that we will be able to educate and guide the younger nurses. And then they have to think also what are the nursing care plan. Risk assessment tool is there. Obviously, you will include that at the time of admission. You are going to take the risk assessment of all patients, and you will also use whenever you are in doubt. Maybe a patient who came on admission may be not at risk, but the next day patient can be at risk. So that takes me to my funny story. Braden scale, which is very normal today for a patient who came walking for TKR. Next day after TKR also you'll have the same number. So then there is a challenge, no, that our nurses had not bothered to look at the Braden scale seriously. They are not applying the tool correctly. So I think there is much that can be done, though this topic, if you look at it, it's not so difficult to understand. You gave all the mnemonics that is required to remember. I really like the she one, stasis, you know, and hypercoagulability. Oh my God, it's tongue twister. Hypercoagulability. And E was for what was that?
Endothelial injury, ma'am.
Endothelial injury. So I'm just repeating that. So I think this is something that we all should show the path. And young nurses, when they come, they're not exposed to all this stuff, and seniors, when we have so much experience, when we are exposed to certain problems, we need to think of newer solutions. If we continue to do exactly what we had been doing. So these two new thoughts came to me in the last few days when I was taking some session. One was in one hospital when I was taking session, they kind of told, discharge summary. And I thought, is there a nursing discharge summary? They said, no, 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 doctor's discharge summary. Then it just struck me, why not have a nursing discharge summary? Why not? Where you actually write what is the condition of the patient, what all education have been given. It can be very easily designed. It's a discharge summary on the day that you are giving to the patient, and you take their signature, and then we take more ownership in the patient's post discharge care as well. And that's also a weak area, because again, patient education, we say we educate patient, but how much they get it, we don't know. So I thought these two ideas, I'm going to give it to the group, whoever is here, and all the people who are going to watch this, recording. And if you decide to try something and it works for you, please do let me know. At least, we will know that all these sessions are leading to some actions. I think that is more important. We all can get a lot of gyan. And I strongly believe if this gyan is not translated into action, then we are not doing justice to our patients, and neither are we doing any justice to our profession. Correct? So, Nisha again, overseas as a nursing discharge summary, including patient education. Good, good, good. So I think At least I have not read about it. These are things that came to me when you are doing a session. So it's very important, that's also very important when you're listening to something, you are thinking, how is this information going to impact what I do in my day to day life? I think pharmacological support has reduced incidence of DVT in non surgical cases. Yes, that is for sure. The awareness of, DVT, VT is very important, but that cannot undermine all the other role the nurses have to do. I think Dr. Shubhangi mentioned when you are giving low molecular weight, heparin, how do you monitor APTT? Do you know what is the right INR for that patient? Do you inform? I can tell you incidents where the INR was suboptimal and the nurse did not do anything about it. And the doctor comes for rounds and then he gets angry. Why this was not informed? So the question is why this was not informed? So there are so many small basic pieces that we still have to cover. I think that is where we should go. And there are great nurses who know all these things and they do all the stuff, but that number is small. That is why we need more and more nurses who are smart. I keep using this word, smart nowadays. We need more smarter nurses to take the place that we want us to have. Using the knowledge we have, we should use critical thinking, and we should let everyone knows that we are here. We can think, we can decide, and we can recommend what needs to be done, and we can take some nursing decisions also, right? I think it was a wonderful session, Shubhangi, and it is 8 o'clock. And thank you, especially Nisha, Swati, and somebody else also was there who were giving good comments and they're interactive. Thank you so
Yeah,
much.
good evening. Yeah, this is Belinda, ma'am. Can I just add on 2 points?
Yes, yes, please, please go ahead.
Yeah, Shubhangi, good presentation. Just
Ma'am.
about this healthcare associated, patients developing deep vein thrombosis. We do a risk assessment for the patients, right? So just like how we do notification for pressure ulcers, and we get to know, patients who are admitted with pressure ulcer and what is the degree of pressure or stage of pressure ulcer, or patients who are what to say admitted with pressure ulcer and we look out for worsening of pressure ulcers. So likewise, when we do a risk assessment for DVT, maybe this is just a thought. We have got quality department, we have got nurses who handle the quality in the given hospital. So if we have some Excel sheet where we can list down the patients who are prone to develop DVT, or who are at the risk of developing DVT, maybe that is how we can identify patients who have developed DVT in the hospital. That is number one. Number two is when patients undergo orthopedic surgeries, mainly the femur bone. These patients are prone to develop pulmonary embolism. So, if any time your patient complains of chest pain, patients having breathlessness, patient saturation drops down, uh, one thing to remember is do not try to mobilize the patients and start the patient on oxygen, and always bring this thought about patient could have developed pulmonary embolism post orthopedic surgeries mainly, or some supra major surgeries or high end surgeries where patient is prone to develop pulmonary embolism. So these are the two uh, points that I wanted to put forth, how we can prevent and how we can identify patients, and maybe use our intelligence in identifying and preventing pulmonary embolism or DVT for our patients. Thank you.
Thank you, Belinda. They are good suggestions, of
Thank you,
course. So,
ma'am.
coming back to the same thing that, how do we use our risk assessment to identify such patients? How do we talk about risk? Each patient has got different risk. How do we tell each others? And now one suggestion that as Belinda was giving, maybe an Excel sheet. So I don't know, maybe a sheet should be with the shift in charge who knows all the patients and they are at risk of something, 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 right? And then drive that as one of their, supervisory goals. Are all the right things being done for the patient? And when we talk about huddle or briefing before the shift, these are the risk that the shift in charge is supposed to be discussing, to say, hey, your patient has got a Caprini score of this, he's at risk of this one. So don't you think that we should be doing one, two, three, four, and like Belinda told, if there are ortho surgeries, especially femurs involving the bones, if you have patients, maybe you will remind them, they are at risk of that in case they develop, so there should be a continuous learning that is happening within the shift itself. So, once again, I'm going back to senior nurses who are running the shifts. Are they aware of these things? Are they knowledgeable? Or are they just passing from one shift to the other, the routine job, and they are going? So, it's very important to use the knowledge one has into the actions, So, I think, yeah, pre or post op transfer, yes, the risk can be everywhere, and a lot has been discussed about the pregnancy as well. I liked, Shubhangi saying that, pregnant ladies are pampered nowadays. Olden time they were asked to sit down and mop the floor. The mother-in-laws, I have heard, the mother-in-laws will say, "Juk ke jhadu karo," you know so I mean, nowadays it is become kind of a disease, it's a normal phenomena. So I think there's a lot that we could discuss, and thank you so much, everyone, for that. If there is anybody else who want to say any comment, I just can wait for 2 more minutes, and then we close this. Thanks a lot, Shubhangi. Well done. You covered all the aspects. Eldos, your video is on. You want to say something?
Yeah, thank you, Mom. I thought I'll just touch on two areas. First of all, thank you, Doc, for a very good presentation. These days, since I'm in Africa, I get rare opportunity to get such online meetings. First one, with regards to one thing which I just wanted to reiterate what Madam Tangam said, we don't have enough role models. I think that is where I really wanted to emphasize. And I can, because being worked in Max for 7 years and moved to Africa, now then I can see, what is the importance of a role model in nursing, how that role model practice can impact the other nursing fraternity. So we were a very small group in Zambia. We started those changes, and last 7 years, the changes I have seen and the best practices we were bringing into the system, it's huge. So I just wanted to reiterate that word, role model. It's not about all the knowledge and degrees and qualifications and credentials we have. It's all about how do we, how do we implement those changes, and you see that patient outcome is linked to our interventions. Whatever we do, if it doesn't impact our patient, and the patient is not in, the outcome is not in the, I don't see it's going to work for any healthcare institution. The last, what I want to mention about risk management, maybe probably I am more into, mining related industries where we provide a lot of support to the mining patients. So every procedure, clinical process linked into mining protocols. That means even if it is an IV cannulation, the first thing which as a quality manager, look at the in that procedure. So every procedure, how big or small is, even if it is clinical or non-clinical or housekeeping, definitely the first aspect is what is the risk involved, whether it is patient related, staff related, infrastructure or environment, we name it. I think that is something which as a fraternity we really need to look into. Everything what we do, there is a risk element. If we do it, if everything goes well, definitely there is a positive outcome. But something goes wrong, like cheese model, somewhere, if we don't put that, and if it happens, then that will end up in any form of adverse event to our patients. Yeah, I thought I'll just share that. And once again, thank you, Doc.
Thank you, Eldos. That's very, very uh, you know encouraging to see young leaders talking, speaking up. about role models. And, I know you are in a difficult industry and you have been able to make a change. So thanks for joining today. I hope next time you will bring some of your Zambian friends also to this, safe, discussion, because safe discussions are happening 7 to 8 p.m. So if you can, yeah, bring them also. Let them also see what happens in India. It will be nice. Yeah.
Yeah.
Thank you so much. Yeah.
Sure. Thank you. Thank
Thank
you.
you, everyone. And thanks once again, Dr. Shubhangi, and congratulations. Well done. I really hope that we shifted the needle a little bit for patient care. I really hope so. Thank you very much. And
Thank
thanks
you,
everyone
ma'am.
for joining, and take care and stay safe. And let's continue doing safe nursing to our patients. Bye bye.
Thank you, everyone. Thank you, ma'am.